Hi, and welcome to another episode of Every Possible Angle. I'm very excited today. I'm joined here by my co-host, Mary Jakoski. Thank you for coming. And we're both very excited to have Dr. Daniel Goldstein here. He is the professor and vice chairman of the Department of Cardiothoracic Surgery at Montefiore Einstein Medical Center. Thank you for joining us.
My pleasure. Thank you.
Obviously, we're very excited to have you here. You've had an incredible career in cardiothoracic transplantation. But to start with, I'd love to hear where it started. How did you get into transplantation in the first place?
Well, it'd be easy actually to tell you how I got into medicine to begin with.
All right.
It's they say everybody's a product of nature and nurture. And in terms of the nature piece, my dad, my grandfather, and my uncle are all physicians. And my mother, who was not a physician, worked with Dr. Wolf in Beth Israel Hospital, as in Wolf, Parkinson, White. So she was actually an EKG technician for him. And my parents met in the hallways of Beth Israel Medical Center. So you can see medicine was part of me, and the heart was part of me because my mom had sort of that experience in her background. In terms of nurture, I trained at Columbia Presbyterian Medical Center, a few miles from where I work now. And as you know, that was probably the premier transplant program. It has been the premier transplant program for many years. In fact, decades. It was the biggest program in the United States for a while. And, you tend to be attracted to what's good in your institution.
Mm-hmm.
So when I was doing general surgery, which predates your cardiothoracic rotations, I was in the ICU, in the cardiac ICU as a second-year resident, and you were the only person with an anesthesia attending taking care of these post-op cardiac surgery patients. There were no critical care doctors or anything like that we'll get now. So I very quickly felt enamored with the field, the intensity, the energy, the way you can affect physiology very quickly.
Mm-hmm.
And with the whole challenges of life and death every day.
Absolutely.
And at the end of the rotation, I approached Dr. Eric Rose, who we all know. He was the the chair of the department at the time, and he had a rematch trial.
Yep.
And I went to see Dr. Rose. I think this is for me. He goes, "Congratulations and condolences." And he accepted me right into the program. I didn't have to apply or anything, which would never happen nowadays.
Yeah.
And I did my cardiothoracic training at the time when pulsatile mechanical support was being tested for the first time in the rematch trial.
Yeah.
And I, in fact, got my name early on into the manuscript describing the design of the trial, the rationale and design of the trial. And later on, we wrote the first article ever in New England Journal about left ventricular assist devices.
Wow.
So that was sort of, my introduction and my how I fell in love with the field, both mechanical support and transplantation.
An incredible place to start. The rematch trial was so foundational trial that it's a great what an entry point into cardiothoracic surgery. I mean, and I'm just curious, going back to your family background, what was that like for being in a family of physicians? I mean, was there and storied physicians? How did that affect you growing up?
I grew up in Venezuela. I was born actually in Montefiore, where I'm at now. So imagine the life being a circle. Wow. My dad was doing his hematology fellowship here.
Yeah.
And I was born here. And then at 6 months of age, we moved back to Venezuela because he wanted to take over his father's practice, my grandfather's internal medicine practice. So I grew up there through high school.
Yeah.
It almost seems like I came out of my mom with a stethoscope in my hand, sort of situation. We didn't have the choices you have now in terms of career tracks and paths and so forth. And it always seemed like the right thing for me to do.
Yeah.
Nobody told me I had to do it.
Yep.
It just seemed like, well, my dad is, my grandfather, is there any other thing? I don't want to be a lawyer, so maybe that's what I'm going to do. And that was it.
That's incredible. And so now you've been at Montefiore for, I think, 19 years now.
Yeah. Yep.
That's and the program is an incredible program. Obviously starting with Rematch, that first pulsatile study, coming to today, the field has evolved incredibly. I mean, tell me a little bit about what that evolution the last, particularly 20 years at Montefiore, what that's looked like.
Is it okay if I show you some things that my audience might like?
Yeah, sure. Absolutely.
All right. So here's the evolution. We come from this
Wow.
to this.
It's incredible. It
Yes.
is incredible.
That is amazing, right?
Right.
Yes.
And
this was what we call the titanium crab. Right? It looks like that. Look at the size of that drive line.
But this was the state of the art at the time, and patients who couldn't receive this had just optimal medical management, had a very poor prognosis. But the extension that this provided at the time, it was fairly limited, right?
That's correct. For the 1 year survival was dramatically different, but after 2 years, everybody died.
Yeah.
Because despite providing a better outcome at 1 year, this device almost always failed and or got infected. You can see the size of this drive line. Not only is it hard to get a date with one of these on, but this is the size of your thumb.
Right.
So it's very, in order for it to integrate and remain a stable dry line exercise and not get infection was very hard.
You're right.
Plus, this thing occupies so much of your body cavity.
Right.
That was limited. So Mary could not fit one of these.
Right.
You and I could with some stretch. The field's come a long ways in terms of reliability, noise, et cetera, quality of life, et cetera.
That's incredible. That is incredible. And I would also, on the transplant side, it seems in the past 20 years, a real surge in transplant. The last year, I think we saw over 4,500 heart transplants, which it's doubled what it was, I think, even just 10 years ago.
Yeah, so transplant traditionally, historically, was not very exciting in terms of the past 10 years or so. Same medications, pretty much the same outcomes, limited access to donors. There's just not a lot of innovation. And a lot of the excitement in the field was surrounding HeartMate 3, a evolutionary transforming paradigm is durable mechanical support. But now that enthusiasm has plateaued, as not a lot of innovation and new academia has come to the field. However, a lot of things are happening in transplantation. They're bringing a lot of excitement into the field. Not so much in the therapeutic aspect, but in the ability to access more donors. And your company is one of them that's actually been at the forefront of increasing our ability to get donors that otherwise we won't. So it's not only the evolution and availability of preservation technologies, but the whole field of DCD, donation after circulatory death, is exploding. There's tremendous interest in the media. There's, porcine xenotransplant experiences that have happened.
And policy changes.
Regulatory policy changes. Juno's being questioned for their abilities to regulate this in a way that everybody's happy. The poor performance of OPOs in general. So there's a lot of things happening in the transplant world. You saw two New York Times editorials focused on transplantation. One by a very famous writer who died after her second heart transplant, and another one saying, "Hey, why can't you sell your kidneys?"
I mean, I agree with you fully. There's been so much change in the last few years in transplantation, and with that, I think it's incredibly the feedback loop that's going on is as you change allocation policy to increase distances, new challenges happen with transportation logistics. You need new technologies. As you open up DCD, then there's new costs and logistics as well there. And so how do we what's exciting to me from the technology standpoint is that the research standpoint is that it's a quickly evolving field. The rules of the game are changing, and so that presents new challenges and new insights. I think, and Mary, with the registry, that's a lot of what you've been looking at. You've been getting a lot of new questions every year.
Yeah, and we're really thrilled that you are part of the Guardian Registry in Heart. And it is a way I've been amazed I've been with Paragonix less than 2 years, and just seeing how much even transplant has evolved, and the use of preservation systems, and even the growth of DCD and extended criteria donors. A third of the U.S. donors we found in the Guardian Registry meet what we would classify as an extended criteria donor. So it's really fascinating to see how the donor pool has evolved as well, and how that's impacting transplant. How have you seen that impact at Montefiore, looking at the donors? Has that changed?
Absolutely. We've abandoned the ice age, right? Although we abandoned that historically many eons ago.
But held on to it a bit longer.
Yeah. We hand out to, we're seeing that. And we were one of the early adopters of DCD. We've gone further. We're taking more risk and feel more comfortable with it. We're almost seeing, with those curves that Barry has shown, where really 6 hours on Paragonix is the same as 4 hours on ice. Right? We've extended what we really consider safe. So really there's nowhere in the United States or even the Caribbean, into Canada, even Alaska, where we wouldn't go to get an organ. So that's drastically improved our accessibility of organs to many of our patients.
And I'm curious, that actually increases, is that increasing volume in the program, and are there ramifications in terms of staffing and infrastructure if you've got more patients on post-transplant that the program's managing? Is that again sort of new challenges caused by the changing field?
Well, I guess that's a geopolitical question, because every program has their own local environments to deal with, and referral patterns and so forth. I think that the whole field of DCD has been a very interesting but challenging one. We cannot predict death.
Yeah, absolutely.
And that's incurring a lot of uncertainty and cost, which sort of balances all the excitement that we have. We're going in a lot of runs, paying for transport and surgeons and so forth. Everything's being outsourced now. Most programs are not,
absolutely,
harvesting their organs. And, many times the donor doesn't die. And you come back empty-handed, but you still have to write a check for the surgeon's time and the flight. Right. And in fact, my administrator just walked into my office half an hour ago to tell me we've had X amount of non-recoveries. And the institution wants to know, is that the standard around the country? Right? I've been here for 19 years. The administration's never questioned, costs of doing business.
Right.
But now this is, it's bringing a light, and something we're going to have to deal with. As, we outsource the harvesting procedure. One of the preservation technology companies requires that they use their own staffing and so forth. And on the other hand, we want to balance the quality of life of our surgeons, our harvest surgeons, our coordinators. So we outsource the whole coordinating process now, because most of the coordinators tend to be young women with kids at home and being woken up 5 times a night while they're on call. Many times are futile endeavors because we don't get the heart. So really the field has changed a lot, and everything is being sort of like corporate America outsourcing these activities. So we're going to have to come, to terms with this whole increased cost. Yes, we're getting organs we otherwise wouldn't, but we need to help. Guardian will help and try to identify who is likely to expire when they take the breathing tube out, and that's a hard question.
That is a hard question. And I think that's, again, I think sort of large collaborative research is some place where we'd like to lean in with that. And I think The challenges you're speaking to, I fully agree that, and that's been a focus of the company is to develop technologies and systems and even services that can be flexible and both help growth, but also do it in a sustainable, financially responsible way for the program. Because if the program can't sustain it, it's difficult. And at the same time, like you said, balancing transplant is for all members, from all the staff, whether it's coordinators or surgeons, the burnout can be quite high because it is as opposed to other areas of medicine, it's a 24/7 operation. Transplants aren't a scheduled procedure; they happen in the middle of the night. You get the calls all the time, and so finding ways for transplant centers to be able to really focus on the transplant itself and to your point, outsource some of these activities where it makes sense and not where it doesn't, I think is one of the key challenges right now in terms of the dynamics sorting out. But I guess actually to that, to what this changing dynamic and what's going on and the evolution, like you said. Recently, along with Dr. Barak, Dr. Silvestri, and Dr. Danishmed, I know that you helped publish, be an editor at the editorial team, and publish this textbook on transplantation and mechanical support.
It's a manifesto.
It is. It's an amazing textbook, and in addition, one of the things that's almost the most impressive part for me is it involves the contributions of 226 leading physicians from the field. Just organizing a group like that seems like quite a feat. Could you tell me a little bit about the process and leadership it took to bring this about?
I'll start by saying I will never do it again. So this project started back in 2020. Yaron Barak, who's a surgeon in Tel Aviv in Israel, was the energy behind it. And him, Manny Daneshman, and Scott Silvestri started this project. I was not involved at the outset. And then they asked me to consider joining. And I said yes, but a lot has to change from what I've seen you've done so far.
Were you very popular at that moment?
So no, I think they sent me sort of a document outlining what the chapters would be and who the authors would be. And I had a lot of ideas how that should change and expand it.
Yeah.
So eventually I became the senior editor of the project and reorganized all the chapters. So it became a 2-volume, 1,440-page endeavor. And there was a lot of people. We wanted to be a multidisciplinary, international, across gender, across ethnicities, across everything. We wanted to get everybody involved. There was a key opinion leader in the field.
Yeah.
And junior people as well. So it turned out to be a 4-year endeavor. It was COVID, remember, so that delayed a lot.
Absolutely.
It's hard to create priorities for other people to make them believe that your priorities should be theirs as well.
Absolutely.
As you well know.
That's so true.
And there must have been 150,000 emails that went by.
I'm sure.
Reminding people and phone calls and editing and re-editing and reformatting and illustrations and so forth. So I'm telling you, I don't think I would do it again. I'm glad to see you guys bought a copy. I told Lisa that she needs to buy a copy for each one of her employees. Let's see how that goes.
It's an amazing book.
And actually, it's fairly up to date because I was doing revisions. I did the entire 2-volume last editing. And a lot of it was done almost a month before it came out.
Absolutely.
So I was adding little things that came out at the last moment.
Absolutely.
So it's pretty up to date. The new Paragonix data is not there, of course, and the latest in OCS and so forth. But I think we covered a lot. And remember, we covered 3 things: lung, heart, and MCS.
Absolutely.
Yeah.
Absolutely. And it's a truly impressive volume. And I think I'm curious, both being at a teaching institution and working on projects like this, do you see as a core part of your mission, beyond helping patients directly, the instruction and education of the next generation of surgeons? How important is that to you, and how does that shape sort of the things you invest your time into?
That's a great point. I think the ethos and sort of the basic tenets of our department is to create a place where the next generation is going to flourish, and leave it as, none of us are going to be here forever, and sort of bring the young up. Eric Rose used to say, the pizza is big enough for everybody to get a slice.
Yeah.
And you bring up everybody along with you, and make sure that everybody has a niche. They have something they're really passionate about, and that they share it with others. So we are very academically oriented, both the heart failure medical part and the surgical part. And we see it as one of the basic pillars of what we do every day. Operating, taking care of patients at the bedside, education and research. Those are sort of the pillars of an academic surgeon, academic cardiologist. And so we're very conscious about not only giving our patients the latest and greatest, but being involved in creating the latest and greatest.
Absolutely.
So here we are.
Well, with the advent of social media, now there are even more direct lines to reach both colleagues and patients. And I think we've seen from you personally, even your activity level on LinkedIn. Through COVID, you not only used it as a means of sharing medical information, but even, your challenges during COVID, and then taking time to enjoy the little things and, your surroundings, and trying to, focus on mental health of your colleagues and patients. I'm sort of wondering how you see that evolving, and how you do look at digital platforms for promoting education, both with colleagues and the medical community and the patient community as well.
Yeah, I think it's also sort of a fascinating way this begun. COVID came. New York was probably the hardest city in the world, hardest hit city in the world. I never thought in my career that I would feel like I would die. I might die going to the hospital.
Yeah.
And that's exactly how I felt, all of us felt. We were displaced from the operating rooms and put in charge of a COVID unit, the 16-bed COVID unit. We used to be a chemotherapy unit.
Wow.
So we had to re-engineer very quickly because we didn't have enough ICU beds.
Right.
And I would dress up basically like an astronaut. Actually, Scott Silvestri sent me this.
Wow.
Oh, wow.
He said he was in Florida. They were very good friends. He said, Daddy, I'm worried about you. I sent you something for COVID. So I wore this thing every day for 3 months or so, every time I walked into the unit. And concurrent with that, I was not only worried that I would die, but that I would bring the disease to my family and they would die.
Right.
So I sent my wife and kids to we have a house in the beach.
Yeah.
And they, for 5 months, from April through September, I believe, they were there.
And you didn't get to see them because you were.
I would get to see them, but I would drive there and I would sit on the other side of the table for dinner.
Yeah.
I would sleep in a different bedroom, of course.
Yeah.
The interactions would be minimal with my family. It was cleaning and, galore. So during that time, I felt, okay, I can't operate. I can't take care of patients like I'm used to. What else can I do? How can I be of service? And I've always been an advocate, perhaps a little bombastic to say I'm an altruist, but I always wanted to help people in other ways. And I decided I want to use social media because it's immediately accessible. I can have a wide-ranging reach to the public. And it's something I've never done before.
Yeah.
And it was a challenge. So I started reading everything there was about COVID, every randomized clinical trial, the emergent science behind it, understanding viral genomes. I had a background in immunology from college. I did college research in immunology and
Yeah,
HIV vaccines, actually.
Wow.
So
Really?
yeah, so I had that in my background, and I started to transmit that to the audience in a very bullet form,
Yep.
right?
Yeah.
So here's the source, but these are the important points you need to know. Boom, boom,
Yes.
boom, 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 and people enjoy that.
Yeah.
95+% of my followers are lay people,
Right.
right? They're not physicians. Let's change a little bit lately. So it was a whole year of doing this, and I would post 3-4 times a day. I had nothing else to do. My family was not there. The restaurants were closed. There was nowhere to go. So I became facile in this and cutting and pasting and quoting, and I got very good at it.
Yeah.
And after that year, LinkedIn elected me as the #1 voice in healthcare for LinkedIn.
Wow.
Which is a platform of 660 million people.
Yeah.
So I developed quite a following, a lot of haters as well. I had a very strong anti-vax community directing, comments at me. It's to expect.
Yeah.
But it was fun. There was a form of giving in a different way.
And I think at the time, for those of us not in New York, like you said, it was such an epicenter, and the experiences were so far extreme. We saw images of ICUs being built like all over the hospital, in patients in the hallways, and these channels to understand what was going on there were actually really important and very compelling.
Yeah.
Absolutely.
It was a unique, I wouldn't say unique, but a unique experience for sure for all of us.
Yeah.
Absolutely.
And I'm not sure how many lessons we've learned. I think we understood that a lot of things went wrong.
Yeah.
From a public health perspective. The way the information got disseminated in particular was not very good by CDC and public health figures. I think we all got caught, so to speak, with our pants down when this happened. And I'm afraid that we're becoming amnestic to what happened.
Right.
It just happened. No, COVID, it's nothing. It's a flu. And the next one's around the corner. We're going to have another zoonotic, respiratory-borne infection that might be worse.
Right.
We're not doing much to be prepared for it.
Taking those lessons and learning. I mean, that's sort of innate in any healthcare program, transplant especially. These quality programs. Right. It's you learn from. I mean, that's the whole point of mortality and morbidity boards is to learn. It's to take a bad situation and how do we learn from it and get better, right? And I think it's if only we can do that on a broader public health perspective. I think that's critical. But one of the things you said, just coming back to it, and one of the reasons you got into social media during COVID was this focus on service. So service does seem something that runs in your veins as well. During the last few years, you've led several cardiac surgery mission trips to Jamaica as part of the Montefiore's One Heart, One Love team. Can you tell us a little bit about that? What was that experience?
I think you guys have really done your research. Did someone steal my CV or something? So there's an interesting story as well. The head nurse of our cardiac ORs is a Jamaican woman.
Yeah.
In a recent trip to Jamaica to visit her dad, who was convalescing in the hospital, it became apparent to her that a lot of young people were dying from rheumatic heart disease. Jamaica, only 5% of the population is insured.
Oh, wow.
So if you walk into the hospital with an aortic dissection, they will ask you to pay cash. Oh. And they say, well, the surgery's going to cost this, the materials are going to cost this, the antibiotics are going to cost this, et cetera, et cetera. You don't have the money. Sorry.
Right.
And that's sadly the way it is in many countries, third world countries around the world. So she came back and says, Danny, can you help me help my people? I said, absolutely. So she had a cardiac surgeon contact at the only university. There's only one hospital that's cardiac surgery in Jamaica, in Kingston.
Okay.
And he remained. So basically, we established a relationship with him, and he would go through his clinics and find patients that needed surgery that couldn't afford it. And I put together a team with her of anesthesiologists, critical care doctors, PAs, or nurses. I petitioned companies to give us the valves for free, the perfusionists to get us cardiopulmonary bypass circuits for free. Wow. So we put together this whole, doing cardiac surgery, you need more than just a plug on the wall. You need a very expensive, the average cardiac surgery is $40,000, $50,000, right?
Right.
Perhaps more. Particularly valves. Valves are $5,000 each.
You're right.
So we put this together, and every January for the past 4 or 5 years, except for a couple of years during COVID, we've gone down there as a team. We pay our own way. We pay our hotel. We pay our food. We donated one of our weeks of vacation and go there to help mostly young patients with rheumatic heart disease get valves, right? Valvular surgery. And it's eye-opening. The infrastructure they have there. The wards are open. The windows are open to nature. Basically, wind comes flying through the units.
Right.
There's little dinty curtains covering one bed to another. It's amazing what we take for granted here. And it's a heartwarming experience in a different way than it is what we do here every day. So yeah, that's been an incredible experience for us.
Coming back to what you do there at Montefiore, I would like to just kind of give a little shout out. Montefiore is actually a fantastic center for transplant as well as other cardiovascular procedures. I mean, you boast last year, your 1 year post-transplant survival rate was over 93%, which is it's excellent. And also, Montefiore has done many firsts, the first coronary bypass surgery back in 1960 before I was born. And all of us, I would assume. And, it's really a phenomenal place, I'm sure, for you to be. What kind of initiatives now, going forward, do you still see coming out of Montefiore or even transplantation that you'd like to talk about?
Yeah, well, I need to update those numbers to just share with the public. The transplant metrics are tightly regulated and updated every 6 months. The SRTR, the Scientific Registry for Transplant Recipients, every 6 months reports the 1 year survivals and risk-adjusted survivals for every solid organ transplant program. And a week and a half ago, 2 weeks, the latest numbers came out. And I'm proud to say we have the best risk-adjusted 1 year survival in the entire country.
Congratulations.
The entire country. Our hazard ratio is 0.34. So we are beyond elated.
Congratulations.
It's hard to be number one in anything, not only in the city, a very competitive market, but in the country where there's 120 plus transplant programs. So yes, part is luck.
Yeah.
And part is a very robust multidisciplinary team that is very well gelled, very focused on our patients, and we're beyond elated, to tell you the truth. So our raw 1 year survival now is 98.75%.
Wow.
Congratulations. That is incredible.
And the hazard ratio is 0.34, which is the lowest of any program in the country. So yes. Yes, we've done a lot of things. I told you, we've always want to not only deliver the best care, the coolest care, the cutting edge care, they want to create that care. So there's two things besides the history of the first pacemaker in the world and the first CABG surgery. We were the first to do an HIV to HIV transplant in the world. And in fact, we are the only ones who've done HIV transplant to HIV transplant in the world. And 2 weeks ago, I did our third one.
Really?
So, and the challenge is there. You might ask, hey, what's so interesting about that? Well, the fact is you're taking a procedure that requires very tough immunosuppression onto someone who's already immunosuppressed.
Right.
And the challenge of doing that. So the operation for me is the same. That's not the issue, but it's the medical management of these complex patients. So we've been at the forefront. We're actually the only ones who are doing this right now. The only ones approved to do it, as a matter of fact.
Yeah.
I think Colombia might be approved as well, but they haven't done one yet. The other thing we do that many programs don't do is we're very respectful of patients' religious beliefs when it comes to blood transfusion in particular. So it's a community, right? Jehovah's Witness community. And many programs are very uncomfortable doing not only transplant, but any cardiac surgery in those patients.
Right.
We're one of the handful of programs in the country, handful meaning really maybe 5, who will do a heart transplant patient who's refusing for religious belief not to accept blood products. We also do LVADs on those patients who require Coumadin therapy. So that's those are the sort of things we're known for. We were one of the first to institute hepatitis C donors and publish data across the country on hepatitis C.
Which that contribution to the community has now led to such growth in a whole donor pool.
Yeah, as well as marginal hearts in terms of ejection fraction. You know, you get called by the OPO, you see ejection fraction 40%, turn it down.
Right.
Well, we don't do that. We learned that dobutamine stress echoes can really demonstrate these people really have normal function, and this is just an impact of brain, heart, LV suppression that gets better, and demonstrably with dobutamine. So those are the little things we've done to try to push the field forward at Montefiore. And I foresee more things coming. We're instrumental in the use of digoxin in LVAD patients to reduce GI bleeding. We did the basic science on that. We'll see. I think there's more coming. I just can't share much of it right now.
Well, I'd also like to remind the audience that you boast this you don't boast, you actually have a 98% survival rate post-transplant while taking these risks and while doing these first. So, you say a lot of it is luck, maybe only a little bit is luck because you're taking risks. So something's going right. You must have a well-oiled team in transplant and both in pre-transplant, preparing the patients, preparing, getting the right donors, as well as post-transplant management. Do you want to talk a little bit about your team and the dynamics within your team a little?
Sure. That's the proverbial village, right? This is soccer, not tennis, right? Tennis, you're one-on-one. Soccer, you got 11 people. Here we have, 30, 40 people. It's we set up a program where everybody has a voice. Everybody sits at the table. Everybody has a vote in determining whether a patient should be a transplant candidate or not. This is not just Dr. Jordy, Dr. Goldstein, the leaders of the program saying yes, no. Everybody's voice is heard. We encourage people to speak up. Many times we're the coordinators and the MPs who know better these patients than we do. Actually, it's always the case. And we found, we've amassed a group of people that just love to do what we're doing. They're challenged every day. We incorporate them into academic and projects, right? How many programs can say, wait, we're pushing our coordinators to present at the podium at ISLT, right? So this attracts a certain amount of people, type A personalities, that really want to push the field forward and not only provide great care, but be instrumental in bringing next knowledge to the world. So luck is, 6 months from now, we're probably not going to be number one, right? Because you have one death or the denominator becomes smaller, numbers change. But we're rejoicing in these 6 months, for sure. And it's nutrition. Psychiatry is huge, right? The biggest barrier to transplantation listing in many institutions, including ours, is poor socioeconomic status because they live in a shelter. They don't have a family. They're using drugs. They don't have a 3-prong outlet.
Right.
These sort of, I could write another book, which you have to buy. In terms of the social challenges in the Bronx, right? We're one of the poorest. We have the poorest, one of the poorest counties in the world, and we're the 6th largest city in the United States. Right, by population, 1.6 million. So we're between Philadelphia and I forgot what other city. So yeah, it's challenging. It's fascinating. It's great to be able to deliver care to underserved population. You know, our majority here is Hispanic and African Americans. Whites are a minority here, which also brings other opportunities for clinical trials and so forth that the FDA in particular is very interested in having seen, because we as a medical profession are not doing a good enough job of being inclusive in clinical trials. Right? You see any clinical trial, you saw it in the LVAD trials, Mary.
Yeah.
80% males, 85% males, 90% white. So these other ethnicities and races might behave differently to these technologies.
Right.
And we just don't know it because we're not including them in the trials.
Well, that's one of the beauties of the Guardian Registry. You know, we get criticisms that it's not a randomized trial, but being a registry in all comers, we don't have those limitations. We really want every sequential patient enrolled because we don't want to just niche our outcomes into certain groups. So, you know, if your transplant community is mostly Black and Hispanic, then the Guardian Registry population for your center is going to match that demographic. So I guess I kind of wonder your thoughts, because you're such a strong clinical trialist, your experience. I mean, I met you many years ago just in clinical trial work, and I'm kind of wondering your thoughts on how you see the evolution of studies in transplant right now, moving forward. You know, registries versus randomized trials, you know, in terms of new devices coming on, or even coming into the LVAD. You know, we started this conversation talking about mechanical support, and it's sort of now with only the HeartMate 3 really commercially available, we know there's more coming down the line. I guess I'm looking to see what your thoughts are in terms of the future of clinical trials in this space.
Yeah, great question. In terms of transplant, you know, the classical randomized clinical trials were medications, right?
Right.
Celsep versus Imuran, or, you know, this drug versus the other drug. And those have ran their course.
Right.
And, you know, most of transplant, I feel like most of medicine is not evidence-based, but eminence-based, right? Expert opinion. Most of what we do in medicine is evidence-based. I think the burning question in our field is whether there should be a transplant versus LVAD trial.
Wow. Yeah.
Right? Have we gotten to that point? And I would think it's a very difficult trial to construct. Why?
Yeah.
Because let's say you're randomized to transplant, but you might not get a transplant for a year or two.
Right.
What if you get sick? You need an LVAD. So there'll be crossovers. An LVAD, you've randomized to LVAD, you can get it whenever. So that's one of the things. Number two, I don't think patients or cardiologists, even some surgeons, are comfortable enough with current technology to say that the quality of life delivered by a transplant and LVAD is similar. I think we made huge strides with HeartMate 3, but we've seen some sort of plateauing in advancement, partly because it's a monopoly. The pipeline is there, but it's moving very slowly. These trials, as you know, Mary, better than anybody else, are expensive, are difficult to do, and anything we do now will take 5 to 7 years to sort of be in the literature.
Right.
And other things will change in parallel. So I don't see a major clinical trial in that regard in terms of transplant versus LVAD. I think we need to get rid of the driveline.
Yeah, absolutely.
Because it's such a major quality of life issue. But yeah, there's a lot of challenges, both economically, logistically, regulatorily, about not having a backup, right? Something happens, plus the transmission to skin, even though it's been done in the past with many technologies, it's seemingly become a problem again. I think the regulation is tighter on that. You know, the patient factor analysis, all this other stuff that is really making it hard to reach that. And, you know, having a monopoly, the company may not be really interested in moving so quickly in that way, particularly when the allocation system is made transplant much easier to obtain. And there's the ongoing bias of transplant is, you got a transplant. It's like, oh my God, I won the lottery,
Mhm.
right?
Mhm. Yeah. Yeah.
They,
Yeah.
Lynn Warner Stevenson used to say, transplant is to heart failure what the lottery is to poverty,
Right.
right?
That's
People people don't say that
yeah.
about LVADs, right?
No.
Right.
LVADs is almost like, okay, I'll get it if I'm dying, and there's no other option.
Right. Right.
And I think that's not a fair treatment of LVADs. I think we have a lot of people allowed 7-10 years with an LVAD doing beautifully.
Mhm.
Um, I don't think we have an equipoise yet
Right.
in the
Right.
field for that trial.
Yeah.
The FDA is very interested, Mary, in alternative ways of doing trials.
Yes, we've
Momentum
seen
was
that.
an example. They adapted trials, and
Mhm.
you can
Mhm.
change things around during the trial. Use of historical, robust historical, cohorts.
Mhm.
Yep.
So they're open
Mhm.
Yeah.
to do stuff differently for sure, and that's it's great.
Absolutely. One of the things you did touch on was that the teams in transplant are so big. It is truly a team sport. It is not just a surgeon going in there doing a procedure and going home. You know, all sorts of specialists, like you said, psychology, therapy, physical therapy, the coordinators, nursing, intensive care. It and that I would imagine coming back to teaching and giving advice to new surgeons in the field is a different part of medicine. Being a leader in a team and getting collaboration in a team and creating that culture, that high performing culture that you've been able to do there, that's not a simple task and isn't necessarily a skill you learn with a scalpel in your hand. Can you tell what advice would you give to a young surgeon looking for a successful career in transplant? What would you, in terms of that side of their development and education?
Number one, for sure, find a good mentor. Right? That is the
True.
most important thing that you can do no matter what part of medicine, probably part of life.
Right.
Find someone who's accessible, who loves to teach, who wants to show you all the tricks and pearls, has the time for you, because that'll be the single most important thing that'll shape your career. It's not easy. You might
No.
not find it in your institution or your medical school. You might have to go elsewhere.
Mhm.
And I think ISLT, for example, is doing a great job. ATS and STS have, sessions for seniors meeting young people, and in small settings.
Mm-hmm.
So the field is doing that, but I would say that's the number one thing.
Absolutely.
The characters of leadership, you have to be collaborative. You gotta listen more than talk. You gotta be open to new ideas. You gotta understand that you have weaknesses and you should work on those weaknesses. You gotta be a great communicator.
Mm-hmm.
You gotta have a certain amount of charisma.
Yeah. No. Absolutely.
You gotta be respectful of everybody in your team, from the person who cleans the floors to the best surgeon in the world. So there's a lot of leadership books you can read out there, leadership courses you can take. But yeah, I think it's a great part of our field, because our field has built-in hierarchies,
Right.
right? And those who strive to become better have endless opportunities in our field to do so.
Absolutely. I can't thank you enough for making time for this conversation, and especially for everything you do, both for patients as well as for the medical community, both in the United States and elsewhere. Before we wrap up, I just want to ask: are there any initiatives or events that you'd like to highlight that are upcoming, either with things like One Heart, One Love or Montefiore's education or in the community?
We do have a yearly heart failure, heart surgery, structural heart meeting, the famous Bronx Heart meeting, that's engineered by my colleague Uli Jorda here, and which you guys have very nicely participated. and helping us sponsor. So that's a tremendous experience for us. It's become one of the go-to meetings for learning what's latest in heart failure and the structural heart disease. That happens usually in the spring, late spring. Besides that, no, but I want to turn the tables on you, and I want you to tell me what is in the scope of Lisa and the company. Where do you see the field evolving? What do you think are the biggest challenges? You have competition, right? There seems to be 3 ways of doing this, right? The temperature control, the normothermic perfusion, and the continuous cold hypothermic perfusion, right? Where do you think things are going to, and what do you think are the biggest challenges for the company?
It's a great question, and I think it's something that we're I'm actually excited about. I think bringing ideas and perspectives from different angles, it makes you get better, it makes you get sharper, makes you continue to innovate, and I think so. In the field of transplantation overall, I think one of the things that we've seen is this improvement in equity of access through the larger allocation systems, and then the technologies that allow you to go all over the country to get organs. With that has come costs, primarily around transportation, and the cost in transplant. One of the major drivers is the private jet industry, right? That's which both has as a cost in terms of dollars towards programs, but also in terms of environmental impact. And so one of the things we're really excited we're looking at, starting in some of the organs that we've seen these longer ischemic times in liver and lung, is actually shifting some of that transportation into commercial aircraft. Which has incredible benefits in terms of equity of access, in terms of just national distribution, in terms of environmental impact, in terms of cost of the system. To get there in a heart, I think is another layer of challenges. How far can we go with time? And we're looking at different areas. We're studying even tighter ranges of temperature control. We're also, the company was actually founded around a cold perfusion system, and where we've advance that technology. We're bringing that into development, and even certain therapeutic agents that we think can help extend that time. Because if we can get to the similar times that we have in lung and liver, we can both increase the pool, increase access to the pool, but do so again, like the focus is in a both financially and in this case, environmentally sustainable approach. So,
well, you forgot something.
Yeah?
To make our lives easier by making transplant a semi-elective procedure.
Yes.
Right?
Right.
And joking aside, that's actually quite critical for a program to grow and serve as many patients as possible. You need rested physicians. I mean, pilots operate better if they have limits on the number of hours they're awake. It's a similar thing, and so it's all joking aside. I mean, we're seeing programs who can really grow by doing in lung and liver space by shifting towards daytime procedure. If we can get there in heart,
right,
that quality of life benefit actually really helps with the ability to serve patients.
We're trained as surgeons, to poo all that stuff. It's like, I'll do a transplant, be up to 2 hours, do a dissection, do a CABG afterwards. And until 10 years ago, I could do that.
Yeah.
Not now. I'm very beat up for 48 hours after being up all night.
Yes.
So that would be a nice thing. And liver transplant, there's actually published data that shows that daytime outcomes are better.
Yeah.
Not only for bleeding, infection, but also survival. In the heart literature, there isn't. The lung literature, there's one paper out from 10 years ago that show the outcomes are the same. From Duke, I believe. But I think everybody would appreciate it. We could do this in a more timely, more.
Like we said, it's a team sport. So if you're working with the team that you are the in terms of the OR team, the transplant anesthesiologist, the nursing team that are a familiar team, a unit that operate all together versus whoever happens to be on staff on a 24-hour schedule. It can make a difference. So absolutely. Well, thank you so much again, both for joining us today. It's been a great conversation, but also for again everything you do for patients, for advancing the field, and your career of service and giving back to the community.
Thank you so much for this opportunity, guys.
Yeah. And we look forward to your next book.
Yeah, absolutely.
I've been told I have to write something based on my my LinkedIn experience. I'm just not sure what kind of framework I will use for that, but we'll see.
Absolutely.
Okay.
Thank you
Right.
again.
Thank you so much.
Thank you.
Bye-bye.